recently got my RN. And once I transition, I hope to start working in the OR to start doing more.
Okay, cool. Doctor?
I am a family physician. I'm actually interested in safe practices for surgery. Surgeries we do are dental.
Okay.
And you know, what I can glean from safe practices for dental
Okay,
surgery.
very good. Michael?
I'm an emergency medicine and critical care physician. Actually spoke at transition stage and special fellowship in critical care, so which I fall into.
Good. Brent?
ER doctor here in McKinney and medical director for a medical supply nonprofit.
Good.
I'm a PA in trauma and regional surgery, looking for where the board might use myself and my overseas long-term.
Good.
I only play a doctor on TV.
Okay, sounds good. Back table here. I don't know all the names for the youth three, I'm sorry.
Pepita Assad, we help enhance medical missions,
Okay.
international missions coordinator.
Okay,
And we have 3 teams that perform surgery.
okay, good. One of the other of you?
Hey, my name is Jenna. I'm a second year medical student at the Medical School in Dallas, UT Southwestern, and interested in surgery.
Oh, it's too bad, you look smarter than that. All right, go ahead.
I work at Loma de Luz Hospital with my husband Jeff, and I just wanted to be here so that if he asked a question.
She started school there.
She directs
She's already
the
got
search. Yeah.
She runs the OR.
All right, good.
She was required to be here, and she obviously wouldn't tell you that.
Sorry to be a little slow here, still working about like I am. What we were supposed to do as part of this scenario, the challenge that we're given was to look over the World Health Organization safe surgery protocol. And so we're going to look at that a little bit. And we're also going to look at the reality. World Health Organization does a wonderful job of sitting in a room and totally divorced from reality, trying to come up with certain guidelines. And so we're going to basically see that, where that can work. Does anybody have any particularly practical issues that they're trying to solve right now? Because we can spend some time on that. Jeff, do you have anything that you ran across in your list?
I think much of the World Health Organization guidelines are things that we do anyway, or that they're relatively common sense, or they become common sense in the practice of surgery. But to me, I alluded to it in the elephant in the room. It's really a question that I have for you also, is that why does no one in the history of the world ever gone to Somalia for their heart transplant? Because there aren't surgeons that are capable of doing a safe heart transplant in Somalia. And if you shipped every possible piece of equipment into Somalia and made it secure and made routes for people to get there, and then populated it with the children of warlords who don't have the expertise to perform the heart transplant, still nobody's going to go to Somalia to get their heart transplant. You know far better than I do, how do you take a population of people who've reached the pinnacle of education in their country and make excellent surgeons out of them?
The answer to that is with great difficulty. I think the other question that is part of that scenario is that the best surgeon in the world is of no value without the proper team.
Absolutely.
You mentioned that earlier.
Yes,
So,
yeah.
Anesthesia is a greater need than surgery, in all honesty. And it does no good to do phenomenal surgery and then have the PACU nurses kill them. And so, it's a multi-step.
I can testify to that from
Yeah.
firsthand experience.
Yeah.
Well, it's also in the World Health Organization introduction into the safe surgery guidelines that the likelihood of an anesthetic death in developing nations is somewhere between 100 and 1,000-fold that in the non-developed world. I mean, in the developed world, But when I was in the Navy, one of the places that I was stationed, where I met was at the Navy Hospital in Naples. And I was the guy that they would fly around to do forensic investigations of any military personnel in an operating room. And usually it was a motor vehicle accident, occasionally it would be some kind of a homicide or something like that, or an injury falling off a cliff. And so I reviewed all of the hospital records as a relative part of routine of, I was a surgeon then, but also this was a tasking of mine. And I never saw an anesthetic record that had more than one set of vital signs on it. In all of the deaths that I saw over a 2.5-year period of time. And it wasn't just in Italy, it was all over the Mediterranean. And this is not an issue that is only confined to the developing world. You know, one would consider a member of the European Union. Many of these countries were EU countries. This was really before the EU, but these were developed nations. And the thing that I could tie it to most directly was their educational process before and during and after medical school. I never saw that kind of problem in Germany or France. I was never called to a death in Germany and France, although I did review hospital records from there. But throughout the Mediterranean, in places where I could identify a rote memory education system and a lack of thresholds for getting into higher education. That is, no entrance exams into medical school, for instance. You just show up, you sign up for it, you get to go to medical school. Countries like that, this was what was routine for me to find, was anesthetic deaths that were a result of ignorance. And I've always, I want to see it better in these countries, but I can't see a better answer to the elephant in the room than starting with kindergarten. And you have met that challenge. I'm really wondering how you...
And we're struggling with it, because I will tell you that I don't think that I've ever been in a mission hospital yet that has an operative note that would meet the criteria for any training program in the United States. And so not only are we having trouble of not getting nationals to necessarily think that way, but we often allow our own standards to slide. And we just think we don't have to fill out all that stuff. That's not necessary. I'll remember all the reasons, that we write that stuff down. Of course, we don't. And so, that's a real struggle.
At Loma de Luz, the surgical guidelines, the WHO surgical guidelines on an operative note, we meet those at Loma de Luz. But visitors have to, a week ago, they were dictating 3-page operative notes. They come with an attitude that that's not necessary.
Yeah, they don't have to do paperwork.
And we have to catch them routinely and say, no, you can't write a one-line operative note here. You need to at least fill in these blanks here. So it is an attitude that you adopt in that, this is not necessary.
Yeah.
It really is.
And I think it's important that we realize that, particularly in surgery, but in all of our medicine, that we have to do it at a standard which brings honor to the Lord.
Yes.
And I won't do bad work for God, no matter what my motivation is or no matter how busy I am. And that's it's a recurring struggle. One of the things that has been real popular over the last 10 years, it was really broken on the entire world by this paper which showed up in the New England Journal talking about the idea of a surgical safety checklist. And I think there's probably nothing that has caused more of a kickback than this relatively simple philosophy. And in this particular thing, if you can't read it, it says here that the rate of medical errors is stunningly high, and he says, well, that explains my hysterectomy. And the real truth is, if we talk about the principles we're trying to, nobody is going to vote against any of these things. Like say, who wants to do a crappy medical record? Well, nobody's going to raise their hand to that, but it gets permitted. So, we all want to reduce error. We all want to reduce complications. We all want to reduce mortality. We want to keep our trained nurses in the operating room. We want to improve job description. We want to improve teamwork. But the reality is, have any of you that worked in operating room surgeons, you ever had wrong side surgery? It's happened. It happened to me because the patient told me which was the wrong side. You know, I mean, and my paperwork said one thing, but this, you know, I was dumb enough to rely on the patient, you know, and he got it wrong. Certainly the wrong kind of surgery, the hysterectomy comment, but much more likely, permits get signed for the wrong things. The patients aren't properly positioned. You get them in there and you actually start the surgery and you don't have things exposed the way you want to. Certainly antibiotics not giving post-operatively. We know the rate of wound infection has to do with that magic window, you know, 30 minutes beforehand. And many times we have the case starting bleeding and all of a sudden we realize that, you know, the antibiotics weren't given. Blood wasn't ready, and that's a real problem, especially in the developing world. The proper equipment, you know, you thought you posted it for something, and that in your mind meant that there would always be this tray and this instrument and this supply, and you get in the middle of it and all of a sudden, oh, that's what you're doing. And everybody scrambles while you try to figure out what's going on. And of course, most of us who flew here are pretty happy about the checklist concept, that the planes did it well. And so a lot of people made a real point about aviation and surgery, and that's honestly somewhat of a false comparison, dichotomy, but there are some lessons that we can learn. They're both certainly high stress, high risk environments, and anything that goes wrong has high consequences as it goes along with it. There's a lot of multi-professional teams that are interacting, and they have to talk to each other, they have to monitor, and there's a lot of non-technical skills. And the non-technical skills in the operating room is some of the most important thing. It is the teamwork that is actually more critical than the skill. Jeff has made a very strong point that if you don't have a good surgeon, it all falls apart. But the truth is, if the team isn't working, it's going to fall apart anyway, no matter how good that surgeon is. And a lot of times the stresses of the team not working, the surgeon's ability deteriorates because he's counting on X, Y, and Z to happen, and it doesn't happen. And so they came up with this whole idea of the safe surgery checklist. And it's a checklist that, as you can see, this was actually, I think, this is in 2013. You can see it actually is taken over in a lot of cultures where this was not part of their routine cultures. I would tell you that a lot of these countries that I know of in Africa, doing a checklist and being compulsive is not part of the culture, and yet it's taken off and it's made a tremendous difference. There's disturbing frequency, and we see this in the United States. It's actually that iatrogenic errors kill more people than a lot of the diseases that we consider the big killers, okay? So in this particular set of statistics, 1 out of every 150 people have some sort of adverse event which leads to their death, okay? So that's 0.6% of all the patients in the hospital will die because of something not going right. That's a frightening kind of number. And 2/3 of those events happen to be associated with surgery or surgical care in some fashion or another. There was a study a few years back in 1991 that kind of started this whole thing. 4% of the surgery patients had disabling injuries. Complications were a big thing. And the thing is that only we tend to want to, and of course if you're a lawyer you say it's all negligence. Only about 1 out of 6 things were truly negligent. The other things were just honestly systems errors that nobody did anything wrong, it just wasn't done right, okay? Now of course the lawyers try to make that all somebody's fault, but it really isn't necessarily an individual response. Again, some other numbers, same kind of things. And they looked at, in particular in surgery, 54% of the events were preventable, but 5.6% of them are deaths. So 1 out of 20 of the mistakes that we make will lead to somebody's death. Most of them were technique related, but it turns out that this is the prevention of at least some of these lies in our hands. And so this is what Gwandi and it's also it's not working. Never locked up. Oh, there it went. Okay. So, and sorry, figure where I skipped ahead here. It went way ahead. So basically, Gwandi and some of the others came up with this 19-item checklist, and they tried it in 8 cities, and it was a prospective study, and they looked at these patients before and after. The rate of death was 1.5%, and afterwards it dropped by 50%, just by doing this 19 checklist. And that was a big deal. And the inpatient complications occurred in 11% of those that were baseline, and after the introduction dropped to 7%. So there was clearly something that went on. The real debate was, does that have anything to do with the checklist? Or is it the process? Is it the pure fact that you're doing it? Okay? In business, in manufacturing, there's a thing called the Hawthorne effect. That if you change something, things improve. And so literally what they have shown is if you're making widgets and you increase the light in the room, now you're making more widgets. Now 3 months later, after the effect's worn off, you can drop the lights again and they make more widgets again. You know, so there is just the whole process that you're paying attention to it that goes along with it. And there was a lot of things. Was, you know, well, this was clearly with 19 items, there's a lot of confounding factors here. There's lots of things that could be doing this. We have the Hawthorne effect. Can you honestly tell me that the complications of surgery had something to do with whether or not you checked off whether you got your antibiotics on time or something like that? That didn't make a whole lot of sense to a lot of people. And it turns out that it didn't always correlate to the checklist. There were places that had 100% correlation, and yet their complications didn't drop as much as other places. So it was clearly not just a checklist, but there was some other ill-defined teamwork, interaction, environment that was set, something that was happening here to make a difference with these. So this is not how you do it, okay? So I'm hoping that this sound will go in here, because I didn't think about that in here.
Okay, let's do our sign in. I've checked all the boxes, so I think we're all set. Okay, it looks like we're all set to go. Can we do our team introductions? Dr. Gwandi?
Team introductions. All right, I'm the surgeon. It's time to go.
Okay, I'm the circulator. I'm Tom.
No. Let's get going. Let's get going.
Can you do your timeout,
We're
please?
working hard.
Can you do your timeout, please?
Richard writes, I guess we're doing a right inguinal hernia repair. This is totally routine. Let's get going.
Any unexpected steps or critical events?
Incision.
Do you want
me to get some antibiotics? Oh.
Anyone want to do the sign out? We did a left inguinal hernia repair, and the sponge counts are correct, so I guess we're all set.
But the point was, they weren't taking this seriously. And so the point is, you have to be serious about the process for it to work. And what we found is that the checklist has been shown to benefit the patient. It benefits the cost, the economics, medically, legally. There's a benefit to the peace of mind. It actually works in emergency cases. It's been demonstrated. You know, one of the problems when a new crew comes in, you get things lost. And that's been reduces that. It's actually reduced equipment problems. It works. And so the point is the team is working well together. So, you know, what should be on the checklist? Well, I'm kind of one of these anal compulsive people that thinks I ought to check everything. Well, it's been demonstrated that doesn't help. So the question is, what are the problems that work in your environment that are really common areas, and make sure you check those, and the rest all sort to fill in. You focus on the killer items. These are the items that are dangerous to skip but are overlooked anyway. If it's something that you all know, you will always 100%, don't put it on the list. It's not the point. We're wasting time if we do that. It's got to be similar, it's got to be easy. And they even say it has to be without the sans serif. You know, sans serif are the little connecting marks. You've got to have it Arial instead of Times New Roman or something. I mean, it's a little crazy. One thing that you do with this is that the checklist is designed to be modified for your environment. Make it work for you. And I will promise you, the first time or the second time or the third time or the fourth iteration, people won't like it, and you'll have to just kind of keep working on it. But I think, honestly, that's part of the process. The fact that they feel part of the team and that they're making a difference with this. it's usually gonna fail not because of laziness or unwillingness, it's just you haven't put it down right. And there's always gonna be a conflict between brevity and completeness and effectiveness. And so the truth is, if it's taking 3 hours to do this, it's not gonna happen. If it's too brief, where it doesn't cover anything, that's not gonna work. So it's actually fairly difficult. The checklist will not stop all error because there are some things you can't protect against, okay? For example, if you don't do this right, it actually makes everybody in the room mad. The teams are frustrated because I needed to get going and now she's making me go jump through all these hoops. So that's part of the problem. You forget the rare stuff. You're not going to ever remember that, and it does not come in a one-size-fits-all kind of thing. What they don't do is they don't create the environment. If the team does not commit to work as a team, there's no checklist in the world that's going to make you do that. Okay? So there has to be a commitment. And one of the biggest problems, I will honestly admit, as a surgeon, is it's usually me or us that don't want to take the time to jump through these hoops. It won't necessarily fit into your present records, and it doesn't prevent gaming. I know people that have sat there and they turn in these reports and they've got 100% compliance, and it was just somebody in the corner checking off the checklist. Okay, that doesn't accomplish what you need. But in most places, people would say that the checklist is a standard of care, and a lot of time. Here's go on to a surgeon at Harvard. He says, sometimes it feels beneath us to use a checklist. It's an embarrassment. It runs counter to deeply held beliefs how truly great amongst us, those we aspire to be, handle situations of high stakes and complexity. The truly great are daring. They improvise. They don't have protocols and checklists, you know. If you ever want an interesting experience, I think it's still on the internet, but you remember when Sullivan put his plane down in the Hudson? They have a recording of his cockpit. And these guys are amazing because they're going from checklist to checklist to checklist to whether it's right, oh, hang on, smack into the water. But the point is that they were doing this very professionally, doing everything they could in the proper order. And of course, that's probably why they lived, is because they were that kind of disciplined professional. And so when we talk about professionalism, we talk about selflessness, we accept the responsibility for others, we expect high skill, we expect trustworthiness, but one of the things that we as surgeons have always pushed is this idea of autonomy. We're in charge, we're the captain of the ship, and the real reality is that for many of us, the real question now is not so much autonomy, but discipline. Do I have the discipline to do this right and to talk to people as we go as well? And Gwandi talks about the fact that this is a big deal. So we're going to skip with just this. The point is, in your hospitals, do the checklists, okay? Because I often have a situation where somebody's coming to watch the surgery and I don't know who they are. You know, I don't know what they're doing there. I don't know if they're actually the local lawyer's representative or, you know, who exactly they are. Likewise, if the circulating nurse is afraid to talk to me as a surgeon, she's certainly not going to tell me to, hey, wait, I've identified a problem because I'm going to chew her head off or something like that. So there has to be this kind of relationship that it really works, and anesthesia is going, and so we've got a 3-level stop. The anesthesia does that when they come into the room. There's going to be a checklist at the start of the surgery that's going to handle the critical points that are important, and then when you're leaving the room, has everything been done properly? So the only other thing then that I would like to kind of go over briefly, and this will be more of an open discussion. Does anybody have any questions about the check? Does everybody use a checklist in their environment?
Is oxygen on the checklist?
No, but you can make an argument that it should be. Okay, or for anesthesia that they've got an oximeter on, or, you know, this is why it's an individual.
I just think it's, in some settings, it depends on how far down the food chain you get, where you're doing a procedure with just a cylinder. If you don't check the cylinder, then you're about to make a big mistake.
The WHO checklist doesn't have to be the checklist that applies to that particular hospital.
Mm-hmm.
I think as Bruce also said, you can modify this to the hospital that you're in. I had a couple of questions. The implementation of a checklist requires a couple of assumptions, and one is that you can speak the language of the people in that group. This conference has a lot to do with short-term medical missions, interfacing with long-term medical missions. And so those involved in short-term medical missions that come into a situation, into a long-term, long-running facility, one, they may or may not speak the language, and two, that checklist may or may not be in place. And I think a checklist attitude is good, not just in the operating room, but in a code situation. In many invasive things that we do in medicine, it can well be applied to that. But if we come into a code in a hospital that you're just visiting, how can you, in some way or another, add that into an already existing status quo or protocol or procedures that people are following? You can't. You have to do it usually in the form of questions. Well, who is this patient, and what's he here for? And you do have to speak the language. And if you can't speak the language, the person who's translating for you has to be not just able to give a word-to-word translation, but understand the medical setting, and so you have to pick your translators pretty well. But I think those are two specific things that in communication that aren't really imagined in the WHO checklist, is that you may be coming into a hospital that doesn't do any kind of a checklist, and yet you've been asked to do surgery there, and you know that it is in the patient's best interest, and you may not speak the language. And many places that you'll go, the language that you might speak might be the first or second or third language that someone in the room speaks, and most of the people speak Kuru, and you speak some French. And those communications are really important. But I think, as you said, the process of stopping and saying, so we're operating for this reason, and this is a left inguinal hernia, right? The patient said left. Can we see the medical record? And you're looking, yes, it says left. That you stopped and did something that people kind of took a toll. You can implement that even if it's not already being done by asking questions. And you need to ask the questions in the language that most of the people there don't understand.
In that setting, I've certainly been in a situation where I was asked to do kind of some sort of either critical or emergency procedure, and I'm sitting there and I don't have the language issues. But one of the things that's so critical then is I have to go through and check and make that all my suture has been pulled, that all my equipment is in the room, so and the right clamps, and I take the time before I even start to make sure. So at least if I can never figure out how to communicate, I can at least do the traditional that one, and know that we can communicate in some fashion. But I think that's a critical point.
Along those lines with language, if you could envision a situation where you have a short-term visiting specialist surgeon who's maybe doing a procedure that isn't normally done in that operating room, where he has a different set of different checklists, because they're not usually doing spine surgery in that room. Maybe he's using a clamp or something that they don't usually have. So to be able to communicate and say, this is called the Jones, whatever, you've got to establish some language.
But I think it's in my private practice, there were certain nurses that were highly qualified nurses that didn't like to necessarily operate with me because I demanded a certain thing, but they could never figure out. They all raved about working with me, and it's because I actually had set them up, the students, to succeed. I'm next, I'm going to do this next, and I think in this setting that again becomes critical to just you're the team leader, but you're trying to get everybody in the room to succeed, as opposed to just get out and getting to the golf course or the other important criteria in one's life. Any questions, comments other than that? Okay. And I think Jeff's point is excellent. We don't have to have a checklist, but checking those same things. Knowing that checklist in your mind. Okay, have you given the antibiotics? Have you got the blood ready? my name is so-and-so, I don't know you, would you please tell me who you are and, you know, what you're doing here? And just, you can kind of do the whole thing and do it. Actually, they actually like that more than the pressure of a checklist.
Right.
But it's just, you know, okay, so we're gonna do this, and I need to make sure that you've got this, do you have it? And do we have blood in the room? And, you know, all the things that you would do to set this up for success when you're dealing with people that may or may not be working at your level of professionalism. These are the points, the objectives that the WHO says that we are supposed to do. Number one, we're to have the correct patient in the correct site. That's kind of a no-brainer, but, you know, clearly that should be as close to 100% as we ever should do anything. Number two, we should use methods that known to prevent harm from the administration of anesthetics while protecting the patient from pain. What does that mean? What can we be doing that might be actually harmful while we're trying to do one or the other?
Not having oxygen to bring them out after the
Okay. Okay, so
first-hand experience.
one is during the hypoventilation to make sure that we're actually, somebody's going to watch them, that they're going to make sure they're breathing,
Oh,
that we make
making
sure
sure
that
that you have oxygen,
your oxygen is
period.
there, making sure you have oximetry, that might fit in that category. And of course, in protecting them from pain, it's always easy to give a slug of narcotics, but do we have the naloxone to reverse them? And although, you know, one of the things, is everybody familiar with the concept of the World Health Organization's essential drug list? That's a joke, okay? It's a great list, but most of the countries don't have them all,
Right.
Yeah.
you know? And so making sure that you have naloxone is there. Obviously, we have to recognize and prepare for life-threatening loss of airway or respiratory function. I have been with poorly trained anesthetists, and this guy has all the signs of a high-risk airway. His chin is back, he's got a swollen tongue, he's got a neck that doesn't move, all these other things. And the anesthetist doesn't have anything special should that airway disappear, okay? And so again, one of the issues that we have as surgeons or in the operating room is to make sure that they recognize the high-risk airway and they actually have some equipment to do that. And as a surgeon, even having the ability to do a surgical airway in case they make the mistake. And so, one of the things that I personally have done all my professional career is I'm in the room when they put the patient to sleep. And I don't care if it's an anesthesiologist there or not. And there are some times where emergencies won't let me do that, but I want to be there because I want to watch it. I'm not going to change anything unless they're doing something totally wrong, but this is an important concept. Recognize and effectively prepare for the risk of high blood loss. Now, the problem that I have is, of course, I never lose any blood. It's always the other guy who loses the blood. But how do we prepare for this kind of situation? Well, this is where the checklist comes in, because it's, do you have the blood? And it's perfectly okay to cancel the case at that point if it's not there, because there's no point in bleeding them to death, okay? And then if we know that we have high blood loss, we've talked about autotransfusion and even the simple things of a chest tube that we can draw the blood off of, or having suction and a young collar and whatever we can do to get some of the blood back from the abdomen, but realizing this is a necessity. What you don't have any luck is actually trying to find that stuff if you haven't prepared for it. And so I think that's an important concept. Avoid inducing an allergic or adverse drug reaction. Well, clearly, the whole point here is we have to make sure that we know what the allergies are and that people understand. And then, I especially with anesthetists that I don't know yet and whether they're any good, what's this patient, what are you giving? And so I run through the checklist in my own mind to make sure that they're not going to do something that potentially hurt them. We want to use methods known to minimize the risk of surgical infection. Okay? So what does that mean? What are the things that we know of increased surgical infection rates? What about just skin prep? What do we do?
Clean the
Sorry?
patient.
Okay, cleaning solutions. And of course, it depends, do they actually have, one of the problems in many countries, they don't really have a ideal choice of an antiseptic. And so a lot of times alcohol ends up being the one of choice, but what's the problem with the alcohol? you must make sure it's 100% dry. Not only for it to be effective, but otherwise we have OR fires, which is something that is not going to be acceptable. So we have to make sure that we understand it. We also have to realize is that if our drapes get all wet, then they're no longer sterile. And the bacteria are going to come back up to it. So just all these things. A sterile field in most mission hospitals is a really unknown concept. Because who trains these people? The surgeons. What do the surgeons know about sterile fields? Not a lot. And so it's actually an area that we have to learn a lot ourselves. The actual principles behind what is second nature to an operating room nurse is not necessarily inherent to the surgeons, and it's not inherent in that setting. Securing identified all surgical specimens. How many of you have pathology where you work? You have it? Okay. I will tell you that I know of one mission hospital in Africa that has pathology. You know, so we have to, anything that we have to do has to get sent off. So that's a need at the level of the anesthetists, or anesthesiologists. I'm sorry, I switched to my British. To anesthesiologists, we need pathologists desperately. So if you know anybody, the Lord's calling them to be an overseas pathologist, they can be used. And of course, again, routine surveillance of surgical capacity, volume, and results. Record keeping. The Lord did not call me to be a record keeper. He called me to be a mission surgeon. But the truth is, you can't do it without it. And the biggest problem we have is we cannot defend what we are doing unless we have the statistics. And we can't certainly raise the money, get the public awareness and so forth, unless I have some numbers to make a difference. I don't know what that's like in South America, but in Africa it's awful. So, okay, so these are the highly recommended things. Okay, this is what they say you should not do surgery, at least at a highly recommended level, without these things. Number one, an anesthesia provider. Well, I know a lot of mission hospitals that are doing hundreds of cases a year without any trained anesthesiologists. It's a combination of spinal anesthesia, ketamine, and a nurse in the operating room. You know, does that mean we shouldn't do it? Does that mean we can't? You know, these are struggles. If the anesthetist walks out, what do you do? And is that acceptable? And is the clinician responsible that's left? And that's a real problem because in the paucity of trained people, sometimes they're trying to run 3, 4, and 5, and 6 rooms. And so they're out of the room and they don't recognize when somebody's quit breathing. So that's a real issue. Supplemental oxygen should be supplied for all patients undergoing general anesthesia. Most of the operating rooms I've been in have had anesthesia. But certainly here, this is where a pulse oximeter with a variable pitch tone loud enough. I want the tone loud enough as a surgeon so that I can listen, because all of a sudden when I hear that beep, 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 you know, I'm going to stop doing what I'm doing and figure out what's going on the other side of the blood-brain barrier there. The adequacies of airways and ventilation, important. If you have mechanical ventilation, using alarms for that system. Do you have all those things at Lone Woods?
So far, yeah.
Great, because it's not true in most of our hospitals. Circulation should be monitored by auscultation or heartbeat or display of the heart rate on a monitor. Many of our places don't even have cardiac monitors. They usually do have a pulse oximeter. Arterial blood pressure determined every 5 minutes. That sounds like the vital signs that you were getting there in Italy and other places, okay? The point is that the anesthetist's job is not to sit up there and sleep. It's actually to monitor the patient. Measuring body temperatures is an issue. Depth of anesthesia by clinical observation. So good anesthesia for all of these things. Now, those are the highly recommended. What if you don't have those? What are your next levels down? The inspired oxygen concentration should be monitored with a mixer that has a oxygen concentration alarm. And there should be an oxygen supply failure alarm on this. In many places, number one, what I've seen happen is they'll use a oxygen concentrator. If you and they never ever do the maintenance on the oxygen concentrators. And so they're putting out, room air is 0.21 and these things are putting out 0.212, you know, or something like that. And so that actually becomes critical. And of course the other thing is, I've had patients get into trouble because the oxygen tank ran out and they never checked it beforehand to see whether it was full. They haven't been monitoring it properly, so these are issues. Capnography. I'm trying to think. I know of one emergency, one or two that actually have capnograms. But those machines are expensive, hard to keep going in that third world kind of environment, and we don't have them. Do you have it done? Good for you. Volatile agents, are we measuring them as volumes and as a true heart monitor? Those are kind of the recommended. There should be a cardiac defibrillator. Most hospitals, the defibrillators don't work, unfortunately. Body temperature should be monitored, and a peripheral nerve stimulator. So those are basically the recommendations. Now, we think in the United States that's no big deal. I'm just telling you there's a huge amount of surgery going on where it doesn't happen, and that is a real risk factor. But what do you do? You know, I know mission hospitals have worked for 20 years at standards well below this, and actually have pretty good results. You know, this is this constant battle between excellence in the Lord's name and not being able to get those resources or keep them working. And, you know, when we have it may be 220, but it's really somewhere between 110 and 440, you know, and you burned out the machines and you put a brand new one up there and 2 hours later it's not working again. And, you know, these are real chronic battles. And this is where clinical expertise, in my mind, is so important. You know, we used to, of course, do anesthesia with just the finger on the pulse and monitoring the patient. It can be done, not as well as some of these other things, but if you have somebody who's out of the room, that's not going to work, you know. And so these are real struggles trying to figure out what to do in a world where people are dying if you don't do it, but you may kill them if you do it. So, comments, thoughts?
That last bit, thinking of earlier, the phrase of no double standards. That seems a bit absurd. Of course there's double standards. Otherwise you would not be doing any surgery. You have to have a double standard. You don't like it, you're striving for better, I get that.
I think that the standards should be the same, but there shouldn't be double standards. You have to make a judgment often on, I can't reach that standard, is the alternative, you know, this patient is before me and they're dying, and I can't do this, but I can do that. And would that meet the standard that you've set? Not always. You don't let go of the standard, lower your standard because you don't have the expertise or the equipment. You work at getting the expertise and the equipment, but you also have to deal with the realities of what you're faced with. So you don't lower your standards, you strive for that as a goal. And there are some situations in which I don't think you should undertake any.
Sure, there's a threshold.
Yes.
Yeah.
Okay.
Are you guys? Yeah.
One of my observations on that is in mission hospitals over time, you tend to develop sort of fatalism of, well, we can't do that because we've never had it. And I can't tell you the number of times that I've had a conversation with, well, why? Well, we can't. And it's, you sort of give up on the standard and you give up on ever trying to achieve it. And I can show up and say, oh, we can solve that problem.
Yeah, the fatigue of well-doing sometimes. You have so many battles to fight.
Right.
That you've done okay with ignoring this one, so, and I haven't solved that one over there, so you continue to try to solve this one without really looking at it. That's an excellent point. Are you guys familiar with the battle for ketamine in this world? Ketamine, of course, is an old drug, but it's probably one of the safest general anesthetic complications. There's, like all drugs, has its downsides. But the Chinese are having a major problem with illicit use. And so they have put through, every year for the last several years, the World Health, they want to have ketamine placed on a level 5 narcotic restriction. Now, given the fact that in most, at least in Africa, any drug above level 2 we can't get, that basically means that we would never be able to give general anesthesia in much of this world if they actually came through with that, because they can't control their drug issues. But I would just tell you to kind of keep an eye out, and when it comes up, do your best to help lobby against keeping the drug. I'm highly sympathetic with their problem, but, you know, 3/4 of the kids in this world are gonna die in the operating room because we don't have the other drugs. You know, the reality is if it isn't spinal and it isn't ketamine, even old-fashioned drugs like halothane are hard to come by. You might get isoflurane, but you're not gonna get much of anything else, you know. And so, and a lot of our anesthetists or the people who function that have never been trained on those drugs either. So, you know, it's a real problem. Ketamine is a lifesaver at multiple levels.
We have it on the ambulances up the road in McKinney even now, and there's kind of a national allotted shortage right now. We've been finding moments for ketamine here locally.
Interesting.
Yeah, great backup.
Yeah.
So Chinese are part of the problem.
Right now, anyway. Yeah. Any other comments about any of those things? Yes?
Do you know anything about if there is education or exposure to either first-time short-term missionaries or long-term to who are used to working here, saying, hey, this is how we do it here because we don't have the things we have here. More of an in-depth conversation of, we don't have monitors, so this is how we do it.
That has basically, there's never been any formal organization, partly because nobody wants to stand up and admit they don't have those things. I mean, that's part of the issue. Yeah, you know, we got standards, no local standards. Most of that occurs, you know, in the first couple of days while you're there. And the real hope is that the emergency doesn't intervene before you get the debriefing on that scenario. One of the real big issues in talking with your friends and so forth, there is a tremendous need for truly highly trained OR techs or surgical tech trainers to go to the third world and train people, because they've been trained by me as a surgeon, and usually that's not really all that well done, okay? It's a matter of having to go through and talk to them and just, you know, what are the really concepts of a sterile field, what's the science behind it? And of course, you also understand that here in the United States, we always throw some political correctness into some of these things that is not necessarily evidence-based. But that's a tremendous need, and I know I can name you a dozen operating rooms right now that would love to have somebody come and give that kind of in-depth training to these folks. And, you know, it's a month at a time in multiple steps, but I've been trying to encourage some people to put together these modules, and they can have a full ministry as OR nurses going around just training other people on how to do packs and how to do the sterilization and how to, you know, how to take care of the instruments properly, and what does a sterile field really mean, and why don't you put too small a drape on, and, you know, all the things that you know, we kind of absorbed. I went through 6 years of residency training. I never got such a lecture either, but, you know, it was beaten into by that one old nurse that, you know, would make sure you did the right thing whether you understood it or not. What we need is some of those old nurses to come and just beat it into a group of other people. It's a great ministry, and it would be helpful. Did you have other comments, Jeff?
I want to make one clarification, just because I don't like to say. You asked if we had pathology, and I didn't understand your question. We do not have in-house pathology.
But you have somebody, a local area. Yeah, like in the Kajabi Hospital does the pathology. There are 250 hospitals across Africa.
Kajabi's a transplant.
Yeah.
A huge hospital into the middle of the state.
But pathology, I mean, there are entire countries without pathologists. And even if you have a pathologist, doesn't mean you can trust him. I can tell you that's another whole other side of the issue. Any questions, any comments, any issues that you found totally freewheeling about surgery, about anything else that we talked about? We've got some time to waste here. And,
Well, my observation, I grew up as a missionary kid in Italy, so I know a lot about the medicine that I was sort of exposed to as a kid. And then I grew up, was trained in the United States, and then went to Honduras, where we now work. And our OR apparently is much more standard to what U.S. standards would be. I've worked in various hospitals, and it kind of strikes me what you're telling me about what's available in Africa, that wow, they shouldn't be doing that, you know. And I work on the mission field, and I'm just kind of surprised, but I don't travel that much. My hands are on the plow, and I work where I'm working. And if our anesthesia machine, our gas reader, isn't working, we have a duplicate. And if one of those goes down, I raise Cain to get it fixed, because I don't want to have, so I think if some of y'all go to these places, stay long enough to make sure that their ORs get what they need. It's a matter of just speaking, because there are generous people out there. And if you make people aware, you don't have to live with the circumstances that you found just because it's a 1-week trip. I'd say extend it. Make the place better than you found it.
Yeah.
Because just because it's a third world place, it can definitely, anesthesia machines aren't that expensive. Gas readers aren't that expensive. All of this stuff that we're talking about as being so amazing, it's like, wait a minute, you can do it, So I would just encourage you to not take second rate as a standard.
Let me add to that if we're talking about short-term missions interacting with long-term mission hospitals in particular, if that's what works in your life, that's what you feel you can do, your family situation, or just that's what you're called to as short-term missions, make a commitment to the same place and return to the same place as much as you can, because you can bring that place up. That's why we meet all these standards, is that we've had help from people who come and visit and then come the next year and then come 6 months later, and they'll bring these screws or this oximeter or pieces of equipment, but also expertise, and they couldn't have done it the first week, but they can do it over a period of time. You can bring a place up. You don't have to go in and accept whatever level that they are, and then go off to another place and accept whatever level that place is. Develop relationships and commitment to one place if that's what God's called you to. But it really helps that one place to have ongoing relationships with people who will bring up the whole.
And the flip side of that, though, is to make sure that they really need and want what you bring.
Right.
Because every one of these hospitals is full of the Jump for Jesus program. Okay? And it's even just because it looks shiny and it's something you use doesn't mean it's going to function in that environment. So that's a critical aspect.
Whereas I was going to say, the flip side of it also is you are not going to fix it in the 2 weeks that you're there. It requires long-term relationship, not 2 weeks. I had a conversation with a guy who was an EMT who had been down to Haiti for 2 weeks and back, and so he was wanting to do some things. I was trying to work through with him the process, and I said, well, are you going to go back there again? He said, no. So he knew what they needed. Having been there for 2 weeks, he knew what they needed. He was trying to raise some money to fix their problem without having any kind of real understanding or long-term relationship. That's just not going to work.
And of course, almost anything that comes in terms of equipment has to come with training, or there's no point in it. The truth is that in most of the level of the anesthetists that I work with, I can give them a capnograph. They just don't know anything about what to do with it, And so it takes weeks of training and someone to help train with that. So it's a whole pattern. It's not just a simple answer of supplying an equipment. It's how do we maintain it? How are we going to replace it? How are we going to handle the disposables? How are we going to, et cetera, et cetera, et cetera, et cetera. It's a whole supply chain situation. And of course, the other issue is if you bring a Ford and the only parts that you can ever get in that place are Chevy parts, and so it really is, you have to really think through this stuff very, very strongly, trying to make it happen.
Bruce, as a non-surgeon, I'm curious if in the modern age of laparoscopic surgery, if you have surgeons who are coming out and aren't prepared to go operate subperitoneal care where there's no laparoscopy for them.
Yeah, that's a real struggle. Our problem is are the people coming out of residency that are going to be career missionaries. It takes them 2 years to learn how to do open surgery or more. And so, you know, we talk about the post-residency fellowship, but it really, for surgery, is a fellowship. They're not much help until they actually get enough experience because they've not done enough cases and they've never done them open. So that's a real struggle. And of course, with laparoscopy, it sounds good, but the cost when you can't get CO2 in the country, or you can't, you know, you have a set of trocars and yeah, we reuse them and all stuff, but the answer is, you know, a brand new set for a hernia. I see hernias that I'd love to do laparoscopically, but they can never handle $600 and some odd in disposable income when they only make $200 for the entire year. You know, so there's, and of course the other thing is that we got lucky in the United States because everybody has gallbladder disease. And so there was a simple operation that you could get early and you know, learn on, and nobody died terribly badly, you know. But when you get over there, if they had gallbladder disease, they've had it for 42 years, and you know, everything's scarred in, and all those things. And you know, there's no such simple thing as simple PID. It's everything's a mess, you know. So there's actually, we struggle in getting enough cases to actually teach people simple laparoscopy. Partly because of cost, but partly because of the whole disease presentation far beyond it. Yeah.
Do you see anything trainees can do to get more prepared to work in a resource board setting, relatively resourceful?
Yeah, actually, there is, if you go on the PACS.net website and go on the resource page, there is a 9-page lecture that I gave on exactly that topic at Louisville and so forth, but looking at some of these issues and how to approach it. The reality is, the more things you have experience with, you know, the more rotations you take, the more, and that don't just concentrate on, say, general surgery, but do urology and ortho and, you know, ENT and, you know, anything like that. All of that will help. Part of it is when you do your fellowship after you get done, since everybody does one now, try to do either a rural surgery fellowship or, you know, some environment where you can kind of sample around. And when you do all of that, you still won't be prepared, but at least you'll be a little bit better off.
Even especially in regard to being trained in the context of modern technology or advanced technology, where you might be working in a place with less advanced technology.
Yeah, there is no solution to the fact that in the United States we don't do open surgery anymore, because nobody will accept that any other alternative. What you can do is make sure that you take your electives overseas, or maybe take your, if you're taking a year off in there for research or doing your public health or something like that, go to a country where you pick up some things. But I think sometimes it's just being aware of what you don't know is helpful, because you know, they're all teachable skills, they're just different skills.
Bruce, I think one area where you can actually get more open experience is in trauma. Some of our trauma surgeons talk about how they're really not that good at laparoscopy because most of their cases are open. So good more trauma surgery.
Jen, I would add one thing to that, and that is, don't become just trained in various aspects of whatever your area of medicine is going to be, but pay a lot of time to all of those people behind you that allow you to do that job. Surgery is going to be an